Okay, so hello everyone. My name is Daniel. I'm a fourth year medical student, and I'm the co-founder of USMLE Forum of Pakistan. And this is our family medicine podcast series. And in this series, we talk about some golden principle of family medicine, right? So, in the previous podcast, I have talked about some osteoarthritis medication. I have ended up my discussion upon that, and I've talked about that if your patient is the first line medication for osteoarthritis is acetaminophen. If it doesn't work, then you will go for NSAIDs, right? So, among the NSAIDs, you got some ibuprofen and endomethacin. That's it. So now let's begin. For suppose you got your on your clinical rotation, and you got a patient of systolic heart failure. Another name for systolic heart failure is heart failure with reduced ejection fraction, and it's almost always due to DCM, dilated cardiomyopathy, right? So systolic heart failures occur due to dilated cardiomyopathy. Your heart is just like a bag, and that loose bag, isn't strong enough to push the blood out of it. So you got a patient of systolic heart failure, and the patient was previously diagnosed with systolic heart failure. Okay, now you're in the ICU, you're taking some notes, you're writing something, and you see that that patient has suddenly developed some palpitations. You're afraid. You see, okay, whoa, what's that? And you also develop some shortness of breath. What's that? What's the thing going on? What you will be thinking of? Whenever, now listen very carefully. You encounter a patient of systolic heart failure, and that patient suddenly develop atrial fibrillation. Think of nothing more, nothing less than and that patient suddenly develop palpitation and shortness of breath. Think of nothing more, nothing less. Just think of atrial fibrillation. Remember, systolic heart failure patients are prone to develop atrial fibrillation. Why? Because in systolic heart failure, the heart is dilated. That dilated heart leads to atrial stretch, and the atrial stretch is a biggest cardiac modeling respector of atrial fibrillation, right? So again, systolic heart failure patient developing palpitation and shortness of breath, AFib patient. Okay, that patient just developed atrial fibrillation, nothing. Okay, another clinical scenario for you. For suppose you got a patient, and they have developed something. You got a patient, and that patient is of 19-year-old, and the 19-year-old guy is a golf player, right? And he visits to your clinic. Oh my God, doc, I'm having a severe pain in my bicipital groove. Just here, I'm having a severe pain. In the layman language, people say that, oh my God, I'm having severe pain at my shoulder. Upon the palpitation, you will see that where the pain actually is. Anyways, the patient complains to you that the patient say, I'm a golf player. I play a lot of golf, and he is 19-year-old, and you see that. The patient say that he is having pain in shoulders. So ultimately, you diagnose some bicipital tendinopathy. Now, remember, those patients with overused tendon injury. This is an overused tendon injury. Bicipital tendinopathy is an overused tendon injury. You use this bicipital, you use this arm back to back, and ultimately you develop bicipital tendinopathy, right? So in those patients with overuse tendinopathy, you just have to go for conservative management. You will give some answer. You will say that take the rest from your sports, right? Don't go just take a break from your daily activity, which involve frequent use of your shoulder or your tendon, right? And you don't go for imaging for such patient. You don't go for X-ray. You don't go for MRI. You don't go for CT scan, all those bad stuff. If there is overuse tendinopathy, just give NSAIDs, conservative medication, the patient is good to go, right? Yeah, but if the pain is persistent, if it is not improving with conservative medication, then you have to think about something else. Okay, then you will be thinking, okay, whatever is happening, it's not just confined to the tendon now. It's not just confined to the tendinopathy. It has it has crossed the limits, and then you will go for imaging. Okay. Uh, Okay, now, for suppose you got a 3-year-old kid, and that kid was playing somewhere. The mother was in the kitchen. No one was there with the child, and the child was playing alone. And suddenly the mother comes, and the patient develops, the 3-year-old boy develops some choking, right? Okay, he's not able to breathe and all. The mother bring to the patient to the emergency department, and there you see that now he's having a choking episode in front of you, and what will you do? Whenever. So first, of course, if the child has developed some choking, that he might have ingested something, or he might have done something bad to his airway tract, right? So in children, okay, choking can also occur after some drowning episode. Anyways, so in patients who develop some choking, in children, I'm talking about children. So those children who develop choking, do not intervene. Let it resolve spontaneously. It will resolve spontaneously within few minutes. So just let's observe for a few minutes. But if the child develops cyanosis, if the child develops shortness of breath, if the child develops loss of consciousness, then you will have to intervene, right? You will go some ETT and all those bad stuff. Okay. Okay. Now, for suppose you got a patient of chronic constipation. The patient just comes to you with chronic constipation and nothing. He's saying nothing. He's saying, "Doc, I'm having chronic constipation." What will you ask? What will be the history step? First of all, you will say, okay. You will ask about some. You will. I can say in the simple terms, you have to rule out the red flags in chronic constipation patients. You will ask, are you having some weight loss? Okay. Do you experience some blood in your stool? Okay. Is there a family history of something else, something like this? You will order CBC, and you will see if there is iron deficiency anemia, or you can just ask the patient that, are you having some symptoms of anemia, like shortness of breath and all those things. And okay, or if this is something appeared as a sudden onset, like you are having those symptoms just 2 to 3 days before, you were never a patient of chronic constipation, but within previous 1 week or 2 weeks, you just have developed these symptoms. So you know what does the actual chronic constipation means? You have the symptoms for months, not just weeks. Anyways, so for such patients, if they have any red flag, you have to go for the workup accordingly, right? If she have developed some thing like if the patient says that he or she has some blood in the stool, you will go for colonoscopy, right? If the patient was previously a patient of Crohn's disease, you will again go for colonoscopy. You will see that if there are not any strictures developed in the small intestine or large intestine or anywhere, right? But again, if there is a loss of weight, you will also think about some chronic carcinoma and all this bad stuff, and you will again go for some colonoscopy, right? So again, you will go for respective managements if there are red flags. But if there is no red flag, so what will you do? You will just go for, again, conservative medication. conservative management. You will say that you have to focus on your diet. You will say that you will say to your patient, you will guide your patient about his diet. You will say, okay, increase the fibers in your diet, increase fluid, you will give some laxatives, and that's how it's gonna work. Okay, that's it. Oh. Mm-hmm. Okay, now another important thing I want to discuss with you, that it is some peripheral artery disease, right? Okay, and justly, first of all, you might have heard about something known as claudication, intermittent claudication, that occurs, for suppose if the patient is for suppose 60-year-old patient with diabetic mellitus comes to you, that, oh my god, doctor, whenever I walk, whenever I do something, I experience a pain in my calf muscles. I experience pain in my calf. Okay, so you will be thinking about two things: either it's a neurogenic claudication, like something related to your nerves, or either it is a vascular claudication, something related to your blood vessels. Now, how you gonna differentiate between these two things? You will first go for ankle brachial index. ABI is a non-invasive gold standard test to differentiate between neurovascular claudication and your vascular claudication, which means peripheral artery disease, right? So you have to differentiate between these two things by a non-invasive test, which is called as ABI. Now, what you do in the ABI, you will measure the blood pressure from your brachial artery, and you measure the blood pressure from your like brachial artery from here. You measure the blood pressure on your ankle, and then you divide those the blood pressure from your ankles from the blood pressure from your brachial artery. And if you get the ratio of greater than 0.9, then it indicates that there is something bad going on with your artery, right? So you will think about peripheral artery disease, right? So just simple as that. First, you got a patient of intermittent claudication. I have told you the symptoms. Okay, intermittent claudication patient comes to you, go for ABI first, ankle brachial index, right? If the ankle brachial index is above more than 0.9, right, so you will think of again peripheral artery disease. But what if this is simple algorithm: claudication, go for ABI. If ABI is more than 0.9, think of peripheral artery disease. It's some vascular claudication. It's not neurogenic claudication. Now, what if the ABI is inconclusive? What do I mean by inconclusive? I mean that ABI is not greater than 0.9. The ABI is not indicating peripheral artery disease. Now, what will you do? You will think of vascular. You will directly think of neurogenic claudication. No, you will first do some imaging. You will go for angiography and all those things. You will do the imaging of the arteries of the lower limb, right? If the imaging of the arteries indicates that it is peripheral artery disease, then you will diagnose, okay, this patient is having vascular claudication. But if the imaging is also normal, if the imaging is also not showing anything bad, then you will think of neurogenic claudication. So it's as simple as that. Just remember, vascular claudication is just another name of peripheral artery disease. So let me summarize. You got a patient of intermittent claudication. You are confused. Either it is vascular claudication means PAD, or either it is neurogenic claudication. The first gold standard non-invasive test you will go for is ABI, ankle brachial index. If it is greater than 0.9, you will think of peripheral artery disease. If it is non-conclusive, you will go for imaging. If the imaging is showing something bad with your arteries, you will think of peripheral artery disease. If the imaging is normal, you will think of neurogenic claudication as a most simplest summary of intermittent claudication, right? So I hope you will end up giving me prayers, inshallah. Okay. Yeah. For suppose now a patient comes to you and she's a female of 21-year-old. That's the best demographic. Female of 21-year-old comes to you, and she has some previously frequent visits of emergency department. Listen very carefully. A 21-year-old female comes to you in the emergency department, and the history shows that she has some previous visits to the emergency department in the recent months. She got recently married, and you upon the examination you see that there are bruises at different stages. There are some bruises in her arm, there are bruises in her neck, and all those bruises in the knee, and all those things. You do now. This clinical picture, I have given you a very obvious finding. In the real deal, it's not that obvious. I'm giving you a classic scenario. So I've given you upon this clinical examination clearly indicates that she is in an abusive relationship. She is in abusive relationship. When you encounter any female with abusive relationship, you will never recommend couple therapy. Never. It's you're doing just really bad if you recommend this. So for such individuals, you will advise, or you will go for some protective services, for some domestic violence services, and they're gonna deal with that. Okay. Another important thing. Let me give you some more important thing. We have just talked about intimate partner violence, right? And there are some risk factor regarding that. The one risk factor is the female. Female are more prone to abusive relationships. Sorry, they are more abused to intimate partner violence. Of course, you have rarely seen a male is getting beaten by his wife, so it's rare. But females are usually female usually got beaten by their husbands. So female is being a female is a risk factor of intimate partner violence. Young age, as I've told you, that she was about 21-year-old, so 18 to 24-year-old is a risk factor for IPV. And low socioeconomic status, pregnancy, and a low educational level, history of child abuse or witnessing some paternal IPV, and history of child abuse or witnessing some paternal intimate partner violence is the risk factor for the one who is doing violence, right? Who is committing violence, right? So it's for husband, right? You can say. Social isolation is also a risk factor, and if the patient is having some disability or chronic illness, I'm talking about the female is having some disability or chronic illness, so that's also a risk factor. Unemployment by male is also a risk factor. If the male is using is in some substance use like alcohol or some bad drugs, so it's also a risk factor. So yeah. Okay. Okay. Now, you know what is radiculopathy? Radiculopathy is something due to herniation of disc, right? For suppose some patient has got some C6 cervical C6 disc herniation, that then you're gonna see the pain in shoulder, from shoulder radiating to their hands, and from hands till these two fingers, right? It is pinky, and it is, I guess, ring finger. Yeah. So the pain will radiate from as to summarize, the pain will radiate from neck to from the neck, shoulder to the hands, right, all along this. So it's a patient of acute radiculopathy. The patient has developed these symptoms just 2 to 3 days ago, or you can say a week prior. Now these patients mostly recover without any intervention. You don't need to go for any imaging. If the patient of acute radiculopathy comes to you, don't go for any imaging or those things. Just go for conservative medication, go for conservative therapy. These patients will recover within few days. But if uh, these patient in okay, if these patients don't recover within 6 weeks, right, you will go for some imaging, right, after initiating the therapy, like some conservative medications. If this patient don't recover, you will go for imaging within 6 weeks. If don't recover within 6 weeks, you will go for imaging. Another important thing I want to tell you, for suppose uh, a patient comes to you with acute radiculopathy, and uh, he's having some red flags, and the red flags are he has some trauma, okay, he got some cancer, okay, that might indicate some your bony metastasis, like breast cancer metastasized to bones, and it can lead to acute radiculopathy. You will go for MRI for that. You have to see are there any osteoblastic lesion. Remember, if the cancer metastasizes, it leads to osteoblastic lesion on MRI. Osteoblastic lesions. Okay, so if the patient has got some IV drug use, or if the patient is having fever, then it is something very bad stuff going on. You, for such patient, you will go for imaging ASAP. Go for imaging immediately, because if the patient has IV drug use, if the patient is having fever, then it might indicate that some infection has is going on at the back, in your spinal cord, or and spinal epidural abscess might be there, and again, you need imaging for that. Or the patient develops some urinary incontinence or some urinary retention, like happens in patients that have something going on at their lower lumbar region, cauda equina, yeah, at the site of cauda equina. So it is also called as cauda equina syndrome. So you will go for imaging for those patients, and after imaging, if you see something, you will do immediate decompression. If you see any abscess, if you see any mass, if you see anything like that, so upon imaging, you will go for immediate decompression. You will remove that mass immediately, and then yeah, that's it. Okay. Okay. Yeah. Okay, let me discuss something regarding conjunctivitis. If the patient of conjunctivitis comes to you and he is having watery discharge, and he has some recent upper respiratory tract infection, you're gonna think about some viral cause like adenovirus, and for that patient, you will gonna continue some conservative and some supportive care. No need for rapid treatment, no need for antibiotics or antivirals. Just go for simply your supportive care like hydration and all those things. Okay, viral conjunctivitis occur bilaterally. Remember this thing. Okay, a patient comes to you with conjunctivitis. He's having purulent discharge. Purulent discharge. Of course, it's bacterial, and you need some topical antibiotics for that, because bacterial. Remember, most of the time in family medicine, when the patient comes to you with viral etiologies, go for conservative or supportive care. But if there is something bacterial, he is having a high fever, he is having purulent discharges, so you'll go for some antibiotics. Okay, now if the patient is having comes to you again, the patient comes to you with conjunctivitis, he's having some itchy, watery, bilateral discharge, no recent sign of upper respiratory tract infection, you're gonna think about some allergic manifestation, and for that you will go give antihistamine, right? Again, a patient comes to you with conjunctivitis. I'm so sorry I'm talking back to back about this thing, but it's important. So a patient comes to you with conjunctivitis. He is having pain. He is having photophobia, means some pain with some pain after exposure to light, and you do some fundoscopic screening of that patient and fluorescent screening, and upon the fluorescent screening you see that he's having dendritic ulcers. Of course you think of HSV. Remember, if any question give you a description of conjunctivitis plus dendritic ulcers, think of nothing, it is just herpes simplex virus. And herpes simplex virus, how to treat it? You have to give a topical and sometimes you have to give per oral antibiotics, right? You give some acyclovir, all those bad stuff, right? Okay, now if a child comes to you with okay, he says that previously the eye discharge was watery, and now from the watery discharge it has changed its consistency to the mucopurulent discharge, and uh, uh, yeah, so you just have to think about the chlamydial conjunctivitis, and you have to give doxycycline for such individuals. You can also give, you will give azithromycin. You don't give doxycycline to the children, especially the newborns. You will give azithromycin to this child, right? Okay. You can also have Neisseria conjunctivitis, but Neisseria conjunctivitis comes with only mucopurulent. There is no history yet. Okay, the discharge was previously watery and it has changed its consistency to the mucopurulent. No, Neisseria conjunctivitis comes with only mucopurulent discharge, and for that you will give ceftriaxone. Okay. 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 Let me tell you something very important. First, suppose if a diabetic patient comes to you and someone asks, what is the most crucial thing to manage? What is the most important thing to manage in a diabetic patient? Blood pressure. You have to manage blood pressure in a diabetic patient. Even it is more important than HbA1c. It is more important than glycemic control, because hypertension in a diabetic patient is lethal, right? Honestly, so you have to manage the blood pressure in a very close range in a diabetic patient. Okay. So let me give you a very important thing. A patient who has recently diagnosed with diabetes, you have to prioritize first of all BP control. It's the first thing. Then you will give metformin. It's an initial agent unless contraindicated. And what's a contraindication of metformin? The patient is having creatinine more than the patient is having the bad numbers of creatinine. There is no specific range, but if the patient is having bad numbers of creatinine, you don't give metformin. You will give some glyburide or something else. Okay. Then you will go for statin therapy if the age is more than 40 or 75, or if the LDL is above 100, you will go for statin therapy. And lastly, you have to go for smoking cessation counseling. So that's a chart that is issued by some authentic authorities, that in the diabetic patient you will first of all prioritize BP control. If the BP control is not there, if you'll first of all prioritize BP control, then you will go for some metformin, you will go for some anti-diabetic medications, and for that metformin is the first line. If the metformin is contraindicated, you will go for some other drugs. If the metformin, and after that you will go for some weight loss strategies, you will say, and lipid therapies, you will give then statin if the patient is between 45 to 75 or 40 to 75, and or if the LDL is above 100, you will also give statin for those patients. And lastly, you will give smoking cessation, and annually you will test retinal changes in those patients, because diabetic patients are prone to develop diabetic retinopathy. So you will go to test, and you will check some angle changes in the retina of diabetic patient. Okay, so that's it for today. I guess we have discussed enough, and that's high yield clinical principle for your step 1 exam, for your step 2 CK exam. And even if you are not an aspirant of USMLE, you can listen to these podcasts to enhance your clinical knowledge. It is way more better than listening to songs while traveling, right? You can listen to these podcasts, and yeah, remember me in your prayers, and thank you. And this is Daniel's test. See you in the next.